Well, welcome everybody. Nundi Andu. Welcome to the race grand round. My name is Paul Worley. I'm the Executive Director for Clinical Innovation in the Riverland, Mallee, Coorong Local Health Network, and it's a pleasure to be on Ngarrindjeri country today. And I welcome you from whatever country you are listening to this and participating as we have the opportunity to step back and explore some of the bigger ideas and perspectives that are influencing our local health network and our world as health professionals. Today, we have started something that will be part of these grand rounds. Yes, we are bringing people from around the world to present our grand rounds and to open our eyes and ears to other ideas. It's also an opportunity for us to present ourselves so that others might be able to hear what's happening. And I thought in doing that, why not put my money where my mouth is and start that process. So today I will be presenting our grand round, and it's a great privilege and honour to be able to do that. So I will attempt to share my screen, and hopefully from there we can move on. So I will ask if people can firstly see that. Can someone respond and say that you can see the screen?
Yes.
Thank you very much. So the Riverland Academy of Clinical Excellence, what is it all about? And the picture there is a monument in Berry acknowledging the place of one of the places of first contact between Western culture and the Indigenous custodians and owners of the land on which this is occurring. And so I want to acknowledge that a lot of what we're talking about here today is a synergy brought together between those two knowledge systems, and aren't we better off for bringing that together? It's also very personal for me. This is a photo of my great-grandparents and their family who emigrated from Scotland to Renmark, and the larger photo is actually of them in Renmark. So this is a place that is also my country. It's also my children's country. Liz and I were working in Lameroo when we had two of our children, Sarah and Alexa. So the health of this country is something that's very dear to my family as well as to everyone who's listening today. When we're looking at an evidence base for what we're doing in race, we really can also build on very esteemed people from around the world. Abraham Flexner undertook a review of medical education over 100 years ago in the United States, and that's influenced the way health professions education has gone into universities rather than just being based in health services. Now, if we look at Piaget and Vygotsky, looking at their understanding of behavioural therapy, behavioural research and social systems. If we look at the work of Norman Doidge and neural plasticity and the understanding of how our brain actually learns and the influences on that learning, particularly around the context specificity of learning. And then we think of Peter Singer around socially constructed learning, and Julio Frank around the implications of the social determinants of health and the work that he's done in leading the WHO. All of these thought leaders bring us to what we're doing in race. But probably the most important people that guide race are the patients. And some of these patients are far more vulnerable than other patients. Rural communities and rural patients are very used to the implications of not having health professionals, because it leads to very severe impacts for them and their families. And we all know these sort of graphs which show as you move further away from the cities, the proportion of health professionals who locate in those areas goes down and down and down. That is a contributor, but is also contributed to by the social determinants of health. Sir Michael Marmot, an Australian who worked for a lot of his life in the UK, has shown the impact of the social determinants. And we know in our region that 12 of the lowest social indice areas in Australia are contained in our 20 SA2 regions across the Riverland. 12 are in the lowest 20%. Tudor Hart summarised this in his law, where he said the access to care varies inversely with the need for care. And a Russian scientist over 100 years ago said, no matter how far our country may advance in medical science, if that science be available to only a select few, that country cannot take pride in its medical progress. Little wonder that in rural areas in particular, there's been a real crisis of trust in our healthcare systems and in the education systems that prepare a workforce. Insanity is doing the same thing over and over again and expecting different results. So how do we respond? One thing I would point out to you is that although this quote has been acknowledged or said to be said by a man, Albert Einstein, in actual fact, it was by a woman. Again, another assumption that underpins a lot of what's been a problem for us in terms of education. So, how can health services respond to all of these challenges that I've outlined? And the answer is to use the available evidence to guide change. And our Riverland, Mallee, Coorong LHN change is encapsulated in what we call the Riverland Academy of Clinical Excellence, or RACE. So what is the evidence base for RACE? First of all, there's a medical workforce rationale for why we're doing what we're doing in RACE. And that is around the evidence around rural origin students more likely to choose a rural career, and living, learning and being mentored in rural areas is more likely to lead to a rural career. So we have the rural doctor pipeline, and this could just as much be the rural allied health pipeline, the rural Indigenous health pipeline, all of our professions. We know that rural student selection is really important. We know that positive undergraduate rural experiences are important. We know that postgraduate rural training and a secure environment in terms of the finances in that postgraduate training are really important. And we know that for those doctors who then stay, skills maintenance, family support, good clinical facilities to work in, appropriate financial reward and good career pathways are all important. And then we know that those high quality rural doctors reinforce all the other aspects of that rural doctor pipeline, which we could just as easily say in the COVID era is actually a rural doctor supply chain. And hasn't COVID shown us that if we rely on our supply chains for external organisations to provide essential services, we can't. It doesn't work. We've seen that in COVID for all sorts of goods and services, and it's just as true for our rural workforce. So there is a medical workforce or a health workforce reason for why we're doing what we're doing in RACE in terms of training locally. But more than that, if it was just that, you could say, well, that's great, but is it a second-class education, essentially, that you're providing? And the evidence is that medical education is moving to demand relevance to society and to demand an emphasis on generalism, which is encapsulated in the term community-oriented medical education. The relevance to society is articulated well by the Training for Health Equity Network that I was a founding member of. This global network looks at socially accountable health professional education, and we are using the evidence in that monograph. The National Rural Generalist Task Force provided advice to the Commonwealth Government that a rural generalist pathway was critical to solving the workforce problems for our country. And the AMC, in its national framework for pre-vocational medical training, has outlined that generalism is key to modern medical education. So there are actual medical education reasons for why we should be training in environments like the Riverland, where we can provide that social accountability and we can provide that emphasis on generalism. But there's more. Medical practice has changed since our current education systems were devised over 100 years ago. There's a change from in the tertiary hospital case mix that means they're no longer the appropriate place for training. And there's a demand by consumers that we have an integrated system with primary care. So let's look at that evidence. Over 50 years ago, White showed that of 1,000 people in a population and 750 who reported an illness in that month, only one ended up in a university medical centre where most of the training has occurred. What that means is that if we're looking to train the next generation to care for all these people in this photograph, and we're actually only exposing them to that person there, that's a mission impossible. We have to somehow expose them to that wider area, which is ideally what we can do in the Riverland Academy of Clinical Excellence. There's evidence around the impact of primary care. Barbara Starfield, a researcher from the United States, in this paper essentially showed this, that an increase in one primary care physician per 10,000 population was associated with a reduction in 34 deaths per 100,000 population. But if you increase any other specialists, there's no change in mortality because you're in addition to increasing the service, you're also increasing complications and unnecessary procedures and investigations. And that's just factual evidence. That's not a critique of the people involved. It's just the model of care. So clearly training in an area that is no longer just the tertiary hospital and has integration with primary care, i.e. the Riverland, Mallee, Coorong, LHN, is going to provide that modern location for relevance for practice. However, our practice is guided by research, and it's recognised that there's a lack of rural academic infrastructure in the country, and yet we still are required to look at evidence-based medicine. So organisations such as the NH and MRC and the Commonwealth Government are looking at implementing an infrastructure for teletrials across Australia. I'm part of that in South Australia, but that's in recognition that we don't have the research infrastructure to enable our patients to have access to the very latest therapies. And if you look at most of the books that are written about the gold standard of evidence-based care, it's all based on evidence that's created in the city, which we then have to translate and deconstruct in order to be able to make it relevant to rural areas. So part of what we're doing in RACE is actually creating that infrastructure for research and how we can create evidence for our practice. Putting those four areas together, we get the evidence-based rationale for race. But there's more than that. If it was just race on its own, well, that's nice, that's fun, that's enjoyable, but why race? Basically, we're doing this because we want improved health outcomes for our community and we want economic sustainability for our communities. What is the evidence that race is going to be able to provide those? Firstly, evidence about our likely socio-economic impact comes from Canada, and we had Professor Roger Strasser present this to us in a grand round a couple of months ago. Health services directly account for at least 10 to 20% of economic activity in rural areas. A health service goes, or that economic activity goes. A health service grows, that economic activity also grows. What they found in the Northern Ontario was that the new economic activity in those small towns was double what the medical school was actually putting in terms of its budget. And more than that, the optimism about what they could also do because they were involved in health professions education grew exponentially to what was invested from the university and the health service. There's also good evidence that social capital is mobilised when you have health professions education occurring in regional areas. And there's a vast literature about the impact of academic health science centres, which is essentially where you're combining research, education and clinical service in an integrated whole, improving health outcomes. So we have evidence that race is not just going to be using the latest medical workforce, medical education, medical practice, medical research. And when I say medical, read health, read allied health, read nursing, because we know that the evidence is similar in all those areas. It's not just utilising that evidence for its own sake, but it's utilising that evidence because we know that we will have impact economically and in health. So our future in race, growing our own health professional workforce across medicine, across allied health, across nursing, across Aboriginal health workforce, creating a locally relevant evidence base for care across all of aged, community, acute, general practice, improving quality as business as usual for our organisation because we have the workforce to do it, because we have a relevant evidence base to do that, providing career opportunities for our staff to be engaged in this enterprise without having to move to the city to seek that promotion, and building hope and prosperity in our communities. If we can do this, what else can we do? When we have our health, we have the ability to think of more broadly about what we can do as economic engines for our country. In the end, better health for all is a better economy for all. Nelson Mandela, from this prison cell in Robben Island, wrote that education is the most powerful weapon with which you can use to change the world. We are using that to change ourselves and to change our world here in the Riverland, Mallee, Coorong region. And we are using the principles and the approaches that are utilised by the WHO and recognised in this document that I was part of writing. No wonder then that people from around the world are going to look at us, because we are an area that is actually looking to implement not just one or two things from the toolkit, but actually implementing the whole toolkit. Because what we've learned is that if you just cherry pick and do a little bit or do another little bit, people still fall through the cracks. We've had 25 years of investment in workforce in this region, and we still have a crisis. So you actually have to shear the whole sheep. You can't just shear the back and say you've done the job. And that's what we're doing in the Riverland Academy of Clinical Excellence. And you know, sometimes it's the right time for this idea. Let's do it together. Thank you for the opportunity to provide that presentation. I will look to unshare now. Hopefully that's come back and been taken off. So we have time for some questions and comments. I'll attempt to chair and also answer questions or comments. I can now see people who are on the screen, but I can't necessarily say that I will be able to see all the hands go up. But the time is there for comments or questions on what I've presented.
I didn't hear you then, but I think you said Vera. Yes, I can't hear you, Paul.
Yes, Vera, yes.
What's your current research that you're doing? I think you've got a few things in the air, haven't you, or that you're doing?
There are currently a number of things that we are doing across the region. We're involved in a collaborative research with SAMRI around filtering out viral particles from air conditioning units in our aged care centres with ultraviolet light. We're looking at research with the Centre for Innovation and Excellence in Health around decreasing waiting times in EDs. We're looking at research in digital care and digital applications. And there is a number of research projects which we are planning with our partners in Aboriginal communities around the region. But one in particular that we're doing with the community at Rauken is looking at an approach to the remission and reversal of diabetes in Aboriginal people who live on Ngarrindjeri country. And that's something that we're very excited about. But yes, there's a number of research projects going on, and they're just the health service ones. There are educational research projects that are occurring as well within the region. So yes, things have started. Any other questions from people?
Not a question, Paul, but it sounds really exciting. There might be some future somewhere.
Thanks, Janine. I think that's one of the things that I've noticed is that as this has been happening, people have caught a sense of excitement that gives them permission, gives them confidence to look at doing things differently, to look at growing and expanding. And I'm sure that was part of the reason that our CEO, Wayne Champion, has pushed the development of this over the last few years so strongly, not just to create an academy, but for what it does for our people in terms of encouraging them to really fulfil their potential in caring for our communities. Yeah, so thanks for that, Janine. Gerida, I think I see your hand up.
Yeah, thank you very much for that. It's really interesting to hear about kind of the evidence base behind how race was formed. I guess one of my questions is about what was the reason behind starting with a medical workforce? We've obviously got workforce shortages across so many components of healthcare. Why was it that you picked the medical workforce to start with?
Look, a really good question, because you say it correctly. There are just as significant issues across our whole workforce. I think the reason for that is probably twofold. The first is that there were some specific funding opportunities that presented themselves and had been presented by state government and by the Commonwealth government around opportunities to build new ways of growing our own workforce. I think the second reason is a historic one, and that is that when we listen to the community expressing their need for a health workforce, they often use the term medical. And if you look at the rhetoric, so if you look at the rhetoric in the current election at the Commonwealth level and the election at the state level, it will often be reduced to we're going to present you with better access to your doctor. And so doctors are often used as a proxy for the whole workforce. So from the community's perspective. So for those two reasons, because that's often seen as emblematic of the whole workforce, and because there were specific funding opportunities, again, because of that historic prejudice, potentially, in the way this is described, we thought, let's do something that we actually think we have a lot of ability to make a difference in quickly, give ourselves confidence, and then expand that. So that's what we're doing this year. We're expanding that to allied health and to nursing. We spent the first 6 months getting things happening in medicine. But it's certainly not a let's do medicine for 5 years and think about the others. No, absolutely not. I hope that gives some perspective.
Yeah, that's very exciting. Thank you.
Are there other questions that people might have? There is one from Janine.
Yeah, sorry about that. Look, how do we follow the progress of it, of what you achieve and things? Is there going to be a homepage set up on SharePoint or a bulletin that comes out that we can increase staff awareness, or what achievements or opportunity?
Yes, really good question. So yes, and yes. That homepage, there is a page already on the LHN's website for race, and we're looking at also developing that for SharePoint, for our SharePoint page, so that people can look at the documents that we're developing and the achievements that are occurring. And we're also looking at what is going to be our strategy for letting people know that in the last 6 months, we have recruited 20 doctors, to an additional 20 doctors to our region. And that's in a region that has about 80 doctors normally. So that's a huge increase. We need to develop ways, I agree, of disseminating that information so that people can engage more quickly. Sharon, you might want to answer that question in more detail because you're the person behind that.
Thanks, Professor. Yeah, we're really excited. In the next month or so, we'll have a hub page up and going where we'll have all our information on there, and all our achievements and our updates and information and bios on all our new doctors. So really looking forward to that in a month or so. We'll hopefully have a CEO bulletin out once we've got that active.
Thanks, Sharon. Certainly, if you want to speak to Sharon or Tash, who are in the Medical Education Unit office, which is part of RACE, they will be able to answer some questions. If you speak to your executive directors, your executive members, they will be aware of what RACE is doing, because RACE is actually part of the whole organisation. As we have mentioned, we've started with medical education and with some specific research, but that's in the context of it being a whole of organisation strategy.
I think that's absolutely brilliant. Thank you very much.
Well, if it's okay with you, I'll take that as the final comment for today's grand round, and I thank people very much for being part of the presentation and the questions, and for being part of RACE. The time is right, so let's use the opportunity that we've been given by our CEO and by our governments to really make a lasting difference in our organisation and in the lives of people in our region. We'll see you in a month for the next RACE Grand Round.
Thanks, Paul.
Thank you.
Paul.
Thanks, Paul.
Thank you.